Welcome, everyone. Thank you for joining us for today's Adult Issues webinar series on the healthcare transition for youth with autism spectrum disorder. My name is Jill Harris with the New Jersey Autism Center of Excellence, also known as NJACE. NJACE is a statewide innovative, comprehensive, and collaborative network to promote quality research, professional training, and to build public awareness aimed to improve the lives of individuals with autism across the lifespan. The center is funded by a grant from the New Jersey Governor's Council for Medical Research and Treatment of Autism to Rutgers, the State University of New Jersey, in partnership with Children's Specialized Hospital. To learn more about NJACE, resources, and goals, please visit our website at www.njace.us. The goal of the Adult Issues webinar series is to build understanding and skills of people with ASD from transition to adulthood through aging. The series is intended for adults with ASD, families, friends, service providers, and the general community. Topics and experts were chosen based on input from various stakeholders, including autistic adults, caregivers, and providers. Some things to remember as we continue. On the right side of your browser, you'll see a chat box that might look something like this. In order to participate in the YouTube live chat, you must sign into your Google or YouTube account. Here is what the sign-in button looks like for both desktop and mobile YouTube clients. Once you click on that button, YouTube should redirect you to the appropriate login page, and afterward will redirect you back to the live stream where you can now chat and ask questions to our presenter. As time permits, the presenter will address your questions at the end of her presentation. Today's webinar is being recorded, and the recording of this webinar will be provided on our website under the Resources Webinars by NJACE tab at a later date. Please check back in a few days for the recording and feel free to share with anyone. We'll also be putting a webinar evaluation link on the YouTube live chat box for participants to complete. The evaluations will provide feedback to help our trainers and also help determine topics for future webinars, so please fill them out. The evaluation is also on our website under the Resources Webinars by NJACE tab for you to complete it there. With that, we're very pleased to welcome our speaker for today, Dr. Tissa Johnson-Hooper. Dr. Tissa Johnson-Hooper has been affiliated with the Henry Ford Health System, or HFHS, for 19 years. She is currently the medical director for the HFHS Center for Autism and Developing Disabilities, or CAD. Her clinical duties include participating in CAD's multidisciplinary diagnostic team and providing primary pediatric care at the HFHS New Center 1 in Detroit, Michigan. She has maintained a long-standing interest in advocating for children with disabilities and has focused her primary care practice on providing high-quality, comprehensive primary care for children and youth with special health care needs. In furtherance of her commitment to children with special health care needs, she developed associations with an array of policy and advocacy organizations, as well as state and national collaborations. Her most recent quality improvement efforts have focused on transition from a pediatrics to an adult approach to healthcare, developmental screening, and integrative mental health initiatives. Thank you, Dr. Johnson-Hooper.
Thank you for the introduction. So, by the conclusion of this presentation, participants will be able to define healthcare transition and understand its significance, identify healthcare transition goals for adolescents with autism spectrum disorder, explore healthcare transition strategies that can be implemented throughout adolescence, and discuss the importance of early planning for transition. So, autism spectrum disorder is a biologically based, diverse neurodevelopmental disorder characterized by persistent deficits in social communication and social interaction, along with restricted, repetitive patterns of behavior, interest, and activities. Now, the latest diagnostic criteria includes severity levels to the diagnosis, which rates severity from level 1, demonstrating support is required, to level 3, representing the need for very substantial support. Severity rating is expressed for both the social communication impairments and patterns of behavior. The prevalence of autism spectrum disorder has steadily increased over the decades. Currently, the prevalence is 1 out of 59. In addition to the behavioral and social communication difficulties of those with of those individuals with autism spectrum disorder, 50% have significant comorbid medical or mental health disorders that require regular medical care. Most common comorbid health disorders include anxiety, depression, GI problems, sleep disturbance, obesity, and seizures. We know that all children deserve a medical home standard of care. This standard of care refers to care that is continuous, comprehensive, compassionate, family-centered, and accessible. A medical home standard of care will ensure that every medical need, both preventative and chronic, are met without any gaps in care and ensures a seamless transfer to adult primary care. Generally, children with autism are quite susceptible to not having a medical home, including the transition to adult care for a variety of reasons. These reasons include provider, both the pediatric and the adult, having lack of knowledge about autism spectrum disorder, limited coordination of autism services, poor reimbursement of the extended time necessary to address the needs of a patient with autism. Without transition support for all children, especially those youth with special health care needs, like children with autism spectrum disorder, the data clearly shows that health is diminished, the quality of care is compromised, and the healthcare costs are increased. Disparities in transition planning for youth with autism spectrum disorder was published in Pediatrics in 2013. This study used data from the 2005-2006 National Survey of Children with Special Health Care Needs to examine the receipt of healthcare transition services for youth, those aged 12 to 17 years, with autism spectrum disorder as compared to youth with other special health care needs. This study demonstrates overall youth with autism experience disparities in access to healthcare transition services. So youth with autism receive healthcare transition services half as often as youth with other special healthcare needs. And youth with autism had a 70% lower odds of being encouraged to take on appropriate responsibility for his or her own health. So what is healthcare transition? So healthcare transition is not that discrete point in time where the young person changes from a pediatric to an adult doctor. Further, for those practices that cares for patients throughout the lifespan, like the family medicine provider or the med-peds provider, healthcare transition is not when that youth goes from being treated like a child to one of an adult. My point is that healthcare transition does not represent one discrete point in time. Rather, healthcare transition is a continuous process, a process that begins in early adolescence and extends through the adult approach to healthcare. The goal of this process is for the youth to achieve their optimal health knowledge and health skills in order to navigate the health system and, as independently as possible, advocate for themselves. So working to achieve a healthcare transition process has included various healthcare transition service models. So healthcare transition care coordinators have been used to facilitate the increase in health literacy, self-management, self-advocacy by helping the youth develop navigation skills. They can provide referrals to adult services and work to facilitate an uninterrupted, continuous care to adult services. A joint pediatric adult clinics like that in family medicine practice, or one in which you have a provider which is double boarded in pediatrics and internal medicine, may provide a practice that facilitates uninterrupted, continuous transfer of care to adult services, improves linkages or communication between the pediatric and adult services, and exposure to an adult approach to care in a supportive environment. Now, another model is a transition clinic. And that's where there is that interim step before that young person transitions to the adult approach to healthcare and really has a focus on adolescent issues. Healthcare transition practice models, they may be disease specific, like those youth that have sickle cell anemia, diabetes, congestive heart failure, or maybe more, the practice model may be more youth adult focus. So while we talk about autism spectrum disorder and healthcare transition, I want to consider these patients. These are patients that I've seen in my practice. Let's consider them. We have first AJ. He's a nonverbal 22-year-old male with autism spectrum disorder, a severity 3, intellectual disability, seizure disorder. He also has multiple sclerosis and worsening self-injurious behavior. He's been my patient since early childhood. He's scheduled for dental work under anesthesia, and he presents for a medical clearance. Then there's GT. She's a 13-year-old girl with autism spectrum disorder, severity 2. She presents for her first visit with me. Her parents report she's healthy. They're concerned with her disruptive sleep patterns and repetitive behavior. They identify the repetitive behavior as her repetitive screen use. Karen she's excited to talk about her kitten collections with me. The last patient is ZM. He's a 16-year-old boy with autism spectrum disorder, severity 1. He also has attention deficit hyperactivity disorder, a tic disorder, and generalized anxiety disorder. His parents report he's doing quite well academically, and he's made progress socially in his new high school. ZM is concerned with his worsening tics, which are blinking. His psychiatrist recently made adjustments to his medications. So I want you to keep my patients in mind as we move our discussion to explore the specific healthcare transition processes. So in 2011, a clinical report entitled Supporting Healthcare Transition from Adolescence to Adulthood in the Medical Home describes the need for healthcare transition to begin at age 12 and extend through the age of 22. This clinical report outlined an algorithmic structure with branching for youth with special healthcare needs. GOT Transition in the Center for Healthcare Transition Improvement is a cooperative agreement between the Maternal and Child Health Bureau and the National Alliance to Advance Adolescent Health. So this organization, GOT Transition, they operationalized recommendations from the 2011 clinical reports on healthcare transition with the development of a structured healthcare transition process they called the 6 core elements to healthcare transition. So I would like to speak to you specifically about this structured process because of its proven effectiveness and ease to which the tools of the 6 core elements to healthcare transition can be customized for use in a variety of service models, practice models, and clinical settings. So when I say clinical settings, that means primary care, subspecialty, pediatric and adult. It can be used in health systems generally, small practices, as well as schools. So the 6 core elements with the recommended ages of implementation include, number 1, transition policy, number 2, transition tracking and monitoring, number 3, transition readiness, 4 is transition planning, the 5th core element is transfer of care, and the 6th is transfer is complete. So both the pediatric and the adult provider has defined responsibilities under each of the 6 core elements. There is shared and equal responsibility between the pediatric and adult providers. So we will review in detail each of these core elements. So the first core element is healthcare transition policy. I like to think of the healthcare transition policy as the rules of engagement. The policy should be shared and reviewed with families. The policy explains what the patient and parent should expect. On the pediatric approach, the policy will focus on how the practice will partner with the youth and family to help the youth develop important health skills and knowledge. On the adult side, the practice clearly outlines the adult practice approach to accepting and integrating young adults into their practice. So both policies should discuss the legal changes that occur at 18 and privacy and consent. The second core element, transition tracking and monitoring, ensures a practice has a mechanism to track an individual patient's healthcare transition progress, as well as a means to track healthcare transition progress for populations as a whole. Then there is the third core element, transition readiness. So a readiness assessment, it's a standardized tool, one which takes minutes to self-administer. It can be used to obtain an objective assessment of the youth's knowledge or understanding of their own health and health skills. Results can be used to individualize conversation, to provide focused education and information in order to promote the youth's health knowledge and health skills. So further, the results may help to set priorities. Readiness assessments should be administered from early adolescence and can be administered multiple times throughout young adulthood. On the adult side, this third core element includes an orientation to the adult practice. So the orientation should include the basics to the adult approach to care, identifying staff and defining their role, describing how to obtain care, such as making an appointment, whether it's on the phone, the internet, or in person. What are the practice's office hours? What do after-hour care look like? How to get prescription, how to contact that new provider. And lastly, orientation could include a welcome letter, which describes confidentiality and privacy. Transition planning, the fourth core element. So transition planning consists of, when necessary, developing a plan of care, which should include a medical summary, an emergency plan of care. Health goals should be outlined with action items, including who's responsible for each action. Specific timelines should be attached to each and every goal. Further, transition planning should include ongoing planning and preparation for changes that occur at the age of consent or age of 18. This core element also includes determining the need for decision-making supports when necessary. Transition to the adult approach should be individualized. So the complexity of the patient really influences the timing of transition to the adult approach or the physical transfer of care. It's not the age of the young person. So youth with complex developmental, medical, or mental health conditions will often have specialists involved in their health, all of which require individualized healthcare transition planning. So the coordination and planning should occur well in advance so that transitions for each of these specialties and primary care are not occurring simultaneously. Because of the advances in medicine, most youth with pediatric onset diseases are surviving into adulthood. resulting in adult providers who may not be experienced in managing a variety of diagnoses, such as autism spectrum disorder. So maintaining communication with that pediatric provider for consultation helps to facilitate a smooth transition. The adult provider can plan for the youth's first visit by ensuring receipt of all medical information, including the most recent readiness assessment, the care plan, any legal documents, and if needed, condition fact sheets. So further planning may include a pre-visit communication, a welcome telephone call, a text message, or email. The fifth core element, the transfer of care, it basically includes a transfer of care of the last pediatric approach or that last pediatric visit. And it includes really just clarifying that adult approach to care, completing the very last readiness assessment, reviewing that readiness assessment, providing needed information and education, and then reviewing the youth's health priorities. So transfer of care on the adult side, or that initial adult visit, includes open communication to address any concerns that the youth may have about transitioning or transferring to an adult approach to care. Reviewing with the youth the transfer package material. Complete or review the most recent readiness assessment. Even with an adult approach to care, the results then should be used to individualize conversation to provide focused education and information in order to promote the youth's health knowledge and health skills. Further, those results may even be used to help priorities even on the adult side. Transfer completion, element number 6. After the youth has left that pediatric approach to healthcare, for youth with complex medical or behavioral health needs, the primary may continue to assist the young adult to connect with adult specialists. Feedback is an essential step with this core element. The pediatric provider should assess the young adult's experience and their perspective regarding the support they received on the pediatric side in order to transition to the adult approach to healthcare. Communicate with the pediatric practice and confirming transfer into the adult practice is necessary on the adult side. They assist the young adult to connect with adult specialists and other support services. They'll continue with ongoing care management tailored to each young adult. And they'll build ongoing collaborative partnerships with pediatric primary and specialty care providers. So thus far, I've identified the roles and responsibilities of the clinician or the pediatric practice or the adult practice, but it really should be underscored that the patient and family are not passive in this process or simply, bystanders. So GOT Transition identified the task of the youth and the family as well. They compiled a set of frequently asked questions organized into the 6 steps that mirror the provider or that mirror the 6 core elements to healthcare transition. So there is number 1, the discovering. What should I be asking my provider about transition? A question that families may want to ask themselves. The second step is tracking. How can I keep track of my healthcare information? And what should I bring with me to my appointments? Number 3, preparing. At what age should I start thinking about transition? How do I become more in charge of my own healthcare? And then as a parent, how can I prepare to let go of managing my child's healthcare? The 4th, as I turn 18, what legal changes in healthcare do I need to know about? The fifth is that physical change or making the change to an adult provider, and most certainly as an active participant in the healthcare transition process, providing feedback to both the pediatric and the adult provider about that process. So completing is the sixth and final step. The Individuals with Disability Education Act requires that schools provide transition planning services for students with disabilities starting no later than age 16. Where appropriate, transition planning must include strategies to build independent living skills. Because making healthcare decisions and coordinating care is an essential independent living skill, preparing students with disabilities to take on these roles during adulthood should be a component of any student's transition plan. So parents may wish to request that the healthcare decision making and transition planning be included as a transition goal in their child's individual education plan. So strategies to achieve this goal could include coordinating with the student's health case manager or their primary care doctor to identify areas of need. If the student receives health services while at school, such as administration of medication, checking blood glucose, or any nursing services. So using these services as an opportunity to teach specific skills should be encouraged. The Individuals with Disability Education Act, or IDEA, requires that schools provide transition planning services for students with disabilities, starting no later than the age of 16. So where appropriate, transition planning must include strategies to build independent skills. Because making healthcare decisions and coordinating care is an essential independent living skill, preparing students with disabilities to take on these roles during adulthood should be a component of any student's transition plan. So parents may wish to request that healthcare decision-making and transition planning be included as a transition goal in their child's IEP. Strategies to achieve this goal could include coordinating with the student's health case manager or primary care doctor to identify areas of need. If the student receives health services while at school, such as getting medications administered, checking blood glucose, or any nursing services, these services can serve as an opportunity to teach specific skills. So as an example, a student may be encouraged to begin reading his or her own blood glucose monitor or dispense the correct number of pills while under the supervision of the school nurse. And then lastly, having a file folder containing important medical records and reviewing those with your young person can be very handy. So now that we've reviewed the 6 core elements to healthcare transition, let's revisit our patients. My patients that we talked about at the beginning of the talk, and think about each of their visits and consider what healthcare transition might look like for them. So while among these patients there is variability in the severity of autism, the presence of both medical and mental health comorbidity, the type of visit, healthcare transition services could be carried out for each of these patients at each of these visits. So one thing should be underscored. Healthcare transition is a continuous process, and all healthcare transition core elements are not undertaken at any one visit. So taking very small bites of the healthcare transition apple at each visit throughout adolescence hopefully will result in patients like ZM, for instance, who, by his age of 16, in my practice, received a healthcare transition policy when he was between the age of 12 or 14. And he and his parents are aware of the healthcare transition journey they're taking in partnership with their primary care physician. The practice would begin tracking his individualized healthcare transition progress, possibly maintaining a registry for youth with developmental or intellectual disabilities to assure core healthcare transition elements are being addressed and are timely. So ZM would have completed readiness assessments, more likely more than a couple of them, with the results used to identify opportunities of improvement. So the patient, provider, and the family could partner to develop a plan to help him gain health knowledge and skills. The provider would provide resources and educational materials to reinforce that information. A comprehensive care plan could be created and updated in partnership with ZM and his parents. And by 16, ZM, his parents, and the provider have begun discussing the changes that will occur at 18. So what levels of support might ZM need, if any? Potential insurance changes, privacy at age 18. They've begun to identify potential adult providers, both primary and specialty, and begun discussing the timing of the physical transfer of care. I do want to share how some of the core elements can be customized for patients with complexities like ZM. So several of the adult specialty societies have created customized transition readiness and self-care assessment with selected conditions. So a customized readiness assessment for parents of youth with developmental and intellectual disabilities, as well as a youth and parent self-care assessment, was created by a collaboration of organizations. These customized tools were modified to a fourth grade literacy level, and like the readiness assessment for youth generally, it's intended to be used to assess the teen's knowledge of their health needs and their skill at managing their health. So comprehensive care plans should encompass a transition plan. So a transition plan is a written document developed jointly with the transitioning youth to establish priorities and a course of action that integrate health and personal goals. So while autism spectrum disorder is a prevalent disorder, many adult providers still hold the assumption that autism spectrum disorder is a childhood condition and that no treatment is available. Further, they're not aware of the high rates of associated comorbidities. The reality, the vast majority of adult providers have received little or no training on autism, whether it be the screening, the diagnosis, or the management of autism while they were in medical school or during their residency. Certainly, while planning to integrate this population into practice, providers should familiarize themselves with the disorder. The provider will have to explore effective communication strategies to connect with their patients with autism spectrum disorder, in addition to knowing medical and comorbid needs. They may need to be aware of the atypical sensory responses and may have to provide anticipatory guidance or modification to their health encounter. The adult provider may consider accommodations such as a very quiet or serene waiting room with few people waiting. If that cannot be accomplished, maybe a page text system for that virtual waiting room. Possibly having exam rooms with the option of low light, extra large screen monitors that both the doctor and the patient can look at together, and most certainly longer clinic visits where there are more complexities to deal with. So in summary, after this talk, I hope that I've been able to stress that all youth with autism spectrum disorder, especially those youth with comorbid medical and/or mental health conditions, benefit from healthcare transition services to optimize their health knowledge and health skills. Healthcare transition is a continuous process, one that should start in early adolescence and extend through adulthood. The 6 core elements of healthcare transition is doable and can be adapted to a variety of settings and patient populations. Comprehensive healthcare transition for youth with autism spectrum disorder will require providers to engage in education and training specific to autism spectrum disorder in order to effectively care for this population. Thank you for your attention.
Hi, thank you so much, Dr. Johnson Hooper. So
Hello. Can you hear me?
yes, just a minute. Okay, so one of the questions that the viewer asked is how the caregivers get lists of providers who accept Medicaid.
That's a great question. I think the first place to start really is turning your Medicaid card over and that telephone number on the back of the card. I'd pick that, I'd call that number and then ask specifically for a list of adult providers that are accepting new patients. I doubt very seriously they would have a list of providers that are accepting young folks with autism spectrum disorder, but that's a place to start. Ones that are accepting new patients. Then the parents, the patients are going to have to do their due diligence, calling, starting making phone calls. And I would encourage to ask very specific questions of new providers. One, are you accepting new patients? Because just because they're on the list doesn't mean they have access in their panel. So if they say, yes, we're accepting new patients, I would be forthcoming saying, I have an autism spectrum disorder, or I have a son or a daughter with an autism spectrum disorder. Would you be willing to take that patient on? But even if the provider says yes, or there's some hesitancy, or if they say no, I think as the parent or that young person, I would follow that up with a little bit of support, saying, would you take on this patient if we provided support and services. As I talked about, adult providers may not know much about autism, but they're more likely willing to learn. So if you upfront say we're willing to partner with you in this process, I think they're more apt to agree to take on a new patient with an autism spectrum disorder. So first, by calling that number on the back of your Medicaid card is the first place to start.
Thank you. And I guess the same would be true. Another question is, how do I find primary care physicians for my ASD sons who are outgrowing the pediatric practice? So I would imagine same advice regardless of what type of insurance they have.
Well, it is the same advice, but let me expand on that a little bit because I want to just make sure I make the point that, I talked about the 6 core elements. In reality, that's a vision. And I think most people listening to this talk, whether you have a young person, young adolescent, middle or late adolescent, or even an adult, may say, well, that's just not the reality that I know. So how do I move forward from here? So to give some practical advice, I think the first thing I would do is, speak to your existing provider, whether it's a pediatrician, family medicine, nurse practitioner, speak to them and say, look, we know adulthood is coming and we need to start to plan. So it's never too early to plan. It's never too late to plan. So if you have that young person and you say, I need to look for an adult provider, will you help me? That primary care provider, that pediatrician, would be able to reach out to their colleagues and ask those same questions. Are you accepting new patients? Would you be willing to see a young person with autism? The pediatrician then is in a unique position. If they've been caring for your young person over the years, they know them well. They know their medical history and what the needs are. So they can offer to serve as a consultant to that adult provider. And often just knowing, the adult provider knowing that they have someone to turn should a problem arise, that's going to give them a sense of ease and they're more willing to take that young person on. So the long and the short is partner with that pediatrician, even if they do not have, those 6 core elements fully integrated into their existing pediatric practice. They still can serve as a consult to the adult provider and can partner with the parents to find the adult provider.
Can you speak some more about how the parents can work with their adult children with autism to help them to be more independent in the doctor's visits or in monitoring their own health?
Certainly. I think that with this paradigm, what the adult or with the parent of an adult child or even a late adolescent, I think oftentimes my families feel a sense of anxiety that adulthood is here and we're not fully prepared. I oftentimes tell families to take a step back and look at the day to day. So as an example, I just spoke with a family this morning on this issue. I always ask my parents, who made this appointment? As parents, particularly working parents, you're multitasking, you're taking care of kids, you often do a lot of day to day, but never necessarily show or provide that expectation the next go round that young adult will take care of that process themselves. So something as simple of how do I get my young person to be more independent in caring for their health? Look what you're doing day to day and not only show them, but talk it through. Say, yeah, it's time for your dental appointment. I'm going to make a phone call. Here's the number. Listen to what I say. So the next time you can say, I'll be here, but you're going to do the talking. Kind of break a large step down into small incremental steps. So really the main point is whether you're making the appointment, walking into the office, filling out paperwork, going through all those steps are things that you just do without necessarily thinking about. So I would encourage parents to start by being mindful of everything they do for their young person with respect to their health. And as you do it in the future, you have that young person sitting right alongside you and you tell them what you're doing, you show them what you're doing, and give them the opportunity to practice what you showed them. That way you're there to correct and support, and they can demonstrate that they've achieved those small incremental steps.
That's a great idea. And for the person with autism who's still in school, where that has a possibility of being built into their IEP, I guess that's one option. For the person who has graduated from school and might be in an adult program or in a post-secondary program. Have you had much success with those programs incorporating health education or promotion of health independence within their curriculum?
That's a great question. So personally, I haven't had any experience, quite honestly, with the post-secondary education, integrating that into their curriculum, mainly because I really work hard at getting my young people by 18 into adult care. That's a great question.
Thank you. And how about, how have you found the role of care coordination within adult practices? You had mentioned how common it is for people with autism to have medical comorbidities, and possibly that might involve them seeing several different medical specialists. Any advice about coordinating that type of care across providers?
So I think that is an area of difficulty, a barrier. When I had the opportunity to kind of query the adult providers within my health system, they identified that care coordination, as well as lack of resources within their practice, as a barrier to delivering care for youth with special health care needs, including those with an autism spectrum disorder. I think it certainly can be done, but it will require some support, from where we are now to where you'd like to be. So if you're talking specifically about a specific example, my advice for the parent or the young person is go into the new partnership relationship with full disclosure that, these are all my providers. I'm going to need help with, be very mindful and clear what you need. The physician, generally ones that I've worked with, while they may not have the experience or the knowledge, they do have a willingness to learn. And rarely have I seen a provider, take on a new patient and really not be willing to provide the best care that they know how. I think that's where that issue is not knowing, but being willing but they are willing to learn. So the providers that I've worked with, when they struggle with the coordination, they do reach back to the pediatrician that's willing to provide consultation, and they offer some level of support on how to coordinate. And eventually they get it and they learn it.
And what about does Medicaid or Medicare or other insurance providers have, can they assign somebody who can assist with that type of care coordination for it to be done through the insurance provider?
So yes, my experience is that, for instance, with Medicaid, they may have a coordinator of the services. It may not be to the extent as what that young person may need, but again, it's reaching out to them. They are a resource, and by saying, it's not just giving me a list of names. I may need a coordinator to assist with communication, and this may be, for instance, if you have a primary care physician in one health system and a specialist in another, where the two do not share electronic medical records or charts. So that is the potential to have some fragmentation of care because of poor communication. So in that example, your insurance, the Medicaid, may have a coordinator that may help facilitate that communication.
Thank you. Another question came up from a viewer. It says, can you discuss the role of insurance providers in transition adult care? It's my understanding that not only is education for doctors a problem, but so is medical reimbursement. And by this, I know that we found this too, that some adult providers are unwilling to take patients with Medicaid or Medicare because the rate of reimbursement is so poor. So any advice about advocacy with insurance in terms of reimbursement and the important role of providing healthcare for adults with special needs?
So surely this is a huge barrier and a huge ongoing issue. Advocacy, whether it be on the individual parent level, certainly is always encouraged. There are certainly organizations, whether they're medical societies or health systems, that always will go and advocate for better reimbursement, because certainly that is an issue when you're not getting reimbursed for the work that the provider does. They're not as likely to take on large numbers of patients who require care coordination or who consume a great deal of time in the office. So it certainly, with respect to this talk, I don't have specific steps that an individual can take. I know from a practice level, providers, I always encourage them to document the time that they're spending with patients, so you only will get reimbursed for if you can demonstrate that you're doing the work, and hopefully with providers coming together, demonstrating, advocating as a group, we can kind of move that ball forward. Obviously, it's nothing that's going to change your, next week, next month. It really is just keeping, due diligence on the work that you're doing, and billing with respect to the time that you spend and the services that you provide, so you can demonstrate to the insurance carriers that we in fact are doing this work. It is hopeful with if many providers that do it, whether you're primary care or specialty, that the payers will see value, and it's going to take time.
Right. Can you comment about if you find the same pattern in terms of the need for transition and difficulty in finding an adult provider for dental care as well? I mean, we've been talking about medical care.
I think, dental care is definitely a barrier. I find this issue to be a big barrier for my kids, that, kids younger than 18, even the preschoolers, the school age kids and adolescents who not just have an autism spectrum disorder, but it's typically an autism spectrum disorder and a significant comorbidity that may really aid or contribute to disruptive behavior. So this is not unique to kids with autism, but I certainly see it in my kids with other developmental disabilities. Finding a developmental dentist or a dentist willing to take on a child who may have behaviors that are disruptive is very difficult. So it's not necessarily a transition issue, but just finding dentists that are, will take the time and have an understanding of the behaviors that may take place. I know one of the things that I have done is I've worked closely with our board certified behavioral analysts, our BCBAs, that will really work with patients to, with a behavioral approach, try to mitigate any disruptive behaviors. So teaching these kids early on, anticipating that sitting in a dental chair, having someone in your mouth will be, a trigger for maladaptive behaviors. So it's not so much this, my response isn't so much of how to find a dentist, but really kind of helping those young people minimize disruptive behaviors.
Right, that's a good point. And we've also had some success in having occupational therapists work with the patient and family for preparation for that too. So it looks like we've covered the questions that came up in our time available. Dr. Johnson Hooper, is there anything else that you would like to cover before we wrap up?
No, I appreciate everyone's time and interest on the topic. And most certainly I'll be more than happy to, if there are other questions that come up, if they'd like to be submitted, electronically, I'd be happy to try to respond to them.
Fabulous. Okay, thank you so much. Really enjoyed this presentation, and I want to thank everyone who's listening. We appreciate your participation as well. So please check back on the NJACE website for future webinars to be posted soon. Thanks again for joining us today, and please don't forget to fill out the evaluation, because that provides helpful feedback and it helps us determine what topics you're interested in. Have a great day, everybody.